document specialty, which is this would be a whole course in this, and behavioral health, because people are wanting that.
Okay, 40 seconds.
My blouse keeps moving on me. I wonder if I can hear Grant or Gary.
Do you want to?
No.
Okay.
I hear Zoe out there. He and Zoe are butting heads.
Okay.
The door's locked. If you can't hear him, we're good.
15 seconds. Can you hear this echoing through my speaker? Oh, good. In 5, 4.
Now I can hear it. Hello, everyone. We are ready to talk about clinical documentation improvement. Now, when you're dealing with auditing, a lot of times people are focused in on the coding. It's all about the coding. It's the E&M, et cetera, et cetera. Is it the CPT? Is it the ICD? Is it the PCS? But we can't abstract those codes without proper documentation. And our role as auditors is to help improve the documentation. Remember, what do? We have the provider that's doing the work, and we're going to translate that into a code set so that it can be captured for statistical purposes. And in addition, it just happens to be the way that we're reimbursed. On top of that, though, we are also training each other, right? So the provider is training us, and we are helping to train the provider so that we can speak the same language. And this all is encompassed in clinical documentation. All right, so, oh, my mouse is in the wrong spot. What are we going to talk about specifically? We're going to talk about the importance of the documentation and continually improving documentation. This is not something that you just do once. This is an ongoing endeavor. We're going to talk about how to establish a clinical documentation improvement program in the office. We're also going to talk about how to improve the documentation and coding. And then we're going to talk about the qualifications and who's going to be the entity or the person that's going to be in charge of that documentation improvement on an ongoing basis. So if we talk about CDI, and that's what I'm going to say from here on out when we talk about it, because we don't need to say clinical documentation improvement again and again. The process is ultimately to make documentation better so that we can do those steps that I mentioned before. Why do we document? To find out what the severity of illness is on each individual encounter. Now, as we think about the disease process, you know, what's the ultimate goal? We want our patient to maintain or get better, right? We don't want them to spiral. We don't want them to go down. And so that's our goal. If we can help them maintain, if they have an illness, something that's chronic, let's say, or improve. And then if it's something that's acute, we want them to improve, right? And not go down. So that is what we're trying to document. What level are we at in that illness, whether it be acute and chronic? Also, we need to document the complexity of care. So if a patient is coming in because they have otitis media, all right, we expect them to improve. You know, it shouldn't go downhill. However, there are incidences when you can have a person that comes in with otitis media, and then it develops into an upper respiratory infection. So now we got two things going on. And then that upper respiratory infection develops into pneumonia. And see how we're going here? We're spiraling down. We're not maintaining or improving. And so what's the complexity of care that we have for a patient that starts out with a simple ear infection that ends up with pneumonia, right? And we also want to document what are the resources that are being used in the practice. Now, we can talk about this from the office level as well as a facility standpoint. So from the office level, what's the resources that are being used? You know, you have your clinician that's involved in the care of the patient, giving maybe an injection, an antibiotic shot. You have your ancillary staff working in the background, taking the insurance information, greeting the patient, making sure that they understand the payment methodology, etc. And then you have somebody probably following up with the patient to make sure that they, you know, got their prescription, that they understand the prescription, et cetera, et cetera. But in between, besides just the provider, you may have the provider reaching out to a peer to get a confirmation of a diagnosis or a thought process, or you know, looking at a specialist. Maybe they're picking up their PDR and they're looking at medications because the patient has an allergic reaction, you know. And so again, there's lots of resources being used in that office, and every single one of those entities in the office, and you can see how that would expand in a facility, is needing to be documented, right? Now, we're not necessarily documenting that the patient, and when they come in the door, is having their insurance information verified, but it actually is being documented because the front desk person, who is that first contact and the impression of the whole office, right, is taking a copy of the insurance card every single time that patient comes in, and so it's documented. Now, the documentation begins and ends with the practitioner, right? And when we say the practitioner, we don't just mean the doctor, the provider. No, we're talking about if we have a clinician, the nurse that follows up with the patient and gives them a call and says, how are you doing? You know, are you feeling better, et cetera, et cetera. So, but that's where the documentation ends. Then that nurse will write in there that, you know, they are following up and any comments and stuff. And then they almost triage, so that if the patient says, you know, no, I'm really having a hard time, I'm still running a fever, et cetera, then that nurse would say, okay, I think we need to get you in here and look at you again. They're triaging the patient, or everything's going fine, and they're going to document that. And it's the validity of the care of the patient that, yeah, we're going to end the care of the patient. They're getting better, you know, and they've been directed to follow up with us if they have any problems, or we're going to bring them back in because the care of the patient needs to be improved, that something's happening. So really, when we talk about CDI, it goes way beyond just compliance and auditing and monitoring, right? It is all about every time that the patient is exposed to that medical professional, you know. And again, we're not talking about just the clinician and the provider, but as a medical professional, I'm including the person at the front desk, you know, to the person that follows up, the triage person, or whatever we want to say that their name is. The CDI program that you have established in your office or your facility, they're going to be that liaison between all of the entities that are working in your office or your facility. So if it's an office, it may be just one person that wears many hats. But if you're the CDI person at a facility, you're part of a team, an ongoing team that is focused, you know, on CDI. It also encompasses the billing aspect, right? Because we want to make sure that the documentation is going to justify the codes that we are using, both the ones that are, you know, constituting our reimbursement. If we're in an office, doctor's office, we're talking about the CPT codes, and that's how we're getting reimbursed. But the ICD codes gives you medical necessity, so you have to have them both, right? And that's where I talked about previously that if you have a patient that comes in and they're having problems with their ears, and the provider cleans out the cerumen in their ears, but he does a full exam on the patient, that ICD code for cerumen impaction is not going to justify a full exam. But if you have the cerumen impaction and then you have a hearing disorder and you have a brain tumor, right? Yeah, that is going to give justification for something a higher level of E&M than just coming in and having, an impaction of cerumen cleaned out. So again, it's a team effort. We're going from again, the point that the patient has first contact, maybe a call to make an appointment, to the time that the patient is being followed up to make sure everything is okay with them after a visit, to even, now let's spread it out, where the bill has gone out and whether it is paid or reimbursed or it comes back with the necessity of more documentation, if it's rejected. So the scope just gets bigger and bigger as we realize that CDI work is never ending and it touches every type of medical professional. When we talk to a practitioner, what we're wanting to get across to them is that it's really all about quality. We want to set up a quality initiative. We want the documentation. It doesn't have to be very wordy to be, capturing everything that needs to be captured, right? It's just that we want to make sure the highlights, that the pieces that need to be captured are actually there. Why? Because we have that old saying that we all know, if it wasn't, if it's not written down, it's not done, right? If it's not documented, it's not done. And now more than ever, we think of that as part of malpractice, right? So that is sometimes what the provider is concerned about, is that burden, that weight of, now I got to pay all this malpractice insurance and I got to make sure that it's, I have everything documented above and beyond so that I don't get sued. But that's really not the thought process that we should have. We should instead be saying that if we have a solid CDI initiative or program in our office or in our facility, then that burden should go away because we're covering everything that we need to. And in other words, if it wasn't written, it wasn't done. And the provider, we have to look at it from their standpoint, because they're there to, make the patient better. Their focus, their primary focus, is to cure or improve the health of that patient. That's all they're thinking about. All of this stuff, other stuff, ends up being ancillary to them, although they know that they have to do or be aware because of everything else, because their name's on the dotted line. And so they're the ones whose head will roll if something's being billed improperly. Medical schools, when they talk about the CDI and the perspective of CDI, they're talking about the care of the patient. That's what they're taught. And you can go out and look at medical schools and training online, especially specialties. So if you go in and look at a cardiologist group and additional training that's going on for them, you can see that they'll talk about, okay, now when you're doing this procedure, these are the things that need to be documented, right? But their perspective, again, is, one, I need to make sure that I document everything that I'm doing to the patient. Two, I need to make sure that I'm documenting everything so that we have a continuity of care, so that, if you're a cardiologist and you're corresponding to your peer that is the PCP for the patient, that PCP has everything they need to know for the continuity of care when they're released from the cardiologist, et cetera. You know what I mean? Or if that patient were to leave and go to another state or whatever, and I need to make sure as their cardiologist that I have everything documented so that when they go to a new cardiologist, they have everything that they need, right? We want that continuity of care. That's what their focus is, the care of the patient. And they rely on the rest of the staff to take care of the billing aspect, the coding aspect, right? And then they're going to, that's why we're that liaison and we're training each other. They train us and say, this is what I need to document from my standpoint. And then you come in and say, all right, this is what I need to see documented to be able to get to the highest specificity with the code set that I'm using. So we're letting them we're not talking about reimbursement. We're talking about, this is what my code set tells me is for this code, this is what I need to see. For this code, this is what I need to see. So if you do procedure X, right, I have a choice between X, Y, and Z over here, you know, and your documentation is a little ambiguous as to the highest specificity out of the three choices that I have. So I want to make sure you educate me so that I know that when I see this documentation that it's X, not Y, and not Z, right? And that plays a part of CPT, ICD, and PCS, all of the code sets, right? And then, so the provider says, okay, when I make this statement, this is what I mean. This is why, you know, and then this is X. When I make this statement, that's what this means. Oh, okay, well, I understand now. Because again, we're not trained as providers, right? So we want them to educate us as to, this documentation means this, and this documentation means this, etc. And then you're educating them as saying, these are the three codes that I have for this procedure. And you know, if it goes above and beyond that, if you're doing something extra, let me know, because there's things that I can do that translates to know that this was above and beyond a normal procedure. I have modifiers that I can use. Or if you didn't do the full procedure, I have modifiers that I can use that tell that story properly. Or maybe this is a better code description as to what you did. I was thinking this, but now that you've educated me, I'm thinking maybe it's this. They say, oh yeah, this is actually the procedure. You know, so again, we are a liaison and we educate each other. So it's much more than with CDI than just picking a code and assigning it to what was done and then billing it out, right? It encompasses everything. When we started using electronic health records, that really helped us in so many ways because it sped up the process. First of all, right? Now, there were facilities and entities that jumped on the bandwagon for using EHRs way before they became a real thing. I remember one of the doctors groups, and they had over 100 providers. They invested in an EHR system right when they started coming out. And it was a major investment for them. You know, it was a lot of money because you know how when anything comes out in the beginning, it's a lot more expensive than it's been out for a while. However, they made that investment so that when it became required, and some of the things that they were required to do, they'd already been doing it for like 10 years. So it was not a problem for them. So that investment in the long term truly paid off for them. And then they were leaders in the industry, especially for that area, to help educate some other entities on, you know, what worked for them. So when we talk about an EHR, you know, there are so many positive things that are connotated to the EHR, but there is also some negatives. And like everything, you know, there's some things that fall through the cracks or stuff that becomes a problem. And the number one thing I think that we can all agree on is that when documentation is cloned or copy and paste, and that should be like that's kind of the bane of our society in CDI work, right? Or just as a general rule, coders and everything, copy and paste, that's a bad word for us, a bad phrase. So we see that being done again and again and again because it's convenient. So it does save time. The problem is there's nothing wrong with taking documentation from an previous encounter and pulling it over to that new document if it's reviewed, right, and updated. That's where we lose it. Is that you have a patient that's been on penicillin for 6 months because the med list is pulled over and just copy and pasted, or you have a person that has good bilateral pedal pulses, but last year or 6 months ago they had a BKA. No, that's not going to work. It's obvious what's happening. They're just grabbing and cloning this documentation. When we look at the EHR, it's important that the provider, as well as everybody else that has a foot in the door with CDI, has input and are all educated on how our EHR works. I think another thing I should throw in there, because this was advice that I was given by the compliance officer for that provider group that I mentioned. She had said, the biggest thing that I see as a mistake that happens with initiating an EHR program is people invest, or these entities invest all the money in this program and they pick one, and it's usually how good the salesman is, because some are better than others, but man, if they sell it, that's the one you end up going with. But they fail sometimes to get a package that is geared toward their specialty. Because of course they were a multi-provider group, so they had several specialties. So they, made sure that the package that they got into would work for multi-specialties. So you had a cardiologist and a urologist over here. They're not using they're using the same EHR, but there are things written in for a cardiologist and a urologist, right? And so they said, and then the second thing they failed to do is get the supplement package that allows them to come back and make improvements as you see errors or you need to tweak the program as you go. She said, because it's expensive, so they don't buy into that part of the package. And yet when you have a problem, 6 months or 2 years down the road, because now you just added a cardiologist to your group that you never had before, and it won't let them, put in something into the system. It keeps rejecting it or whatever. They have no way to fix it. They have no way to fine tune it. And she said, that's a problem. So everybody has to have a look and say, the compliance officer, the CDI specialist, the people at the front desk, the practitioners, meaning the ancillary staff as far as the MAs, the LPNs, the RNs, the respiratory therapists, the lab, as well as radiology and everything, and then also the providers. They all are working together on this documentation. They have a say in their EHR. So when back in 1995, they started changing the way a little bit that they were teaching the providers about documentation, and they started doing the E&M services. The providers realized, okay, now we're being reimbursed via the complexity of the patient. And we'll go back to our gentleman that comes in with cerumen in his ears, right? If they're just having a cerumen impaction bilaterally, and that's all that's done for the patient, the medical decision making is not that high. with the E&M. However, if you have those other things going on, like a, disorder with the hearing as well as a brain tumor, oh wow, medical decision making just went up. Yeah, maybe the final thing that you ultimately do is clean out the impaction in the ear, but what if that doesn't relieve the signs and symptoms that the patient has, right? Then the medical decision making just went up. Do we need to go and do some tests? Do we need to, do an MRI? Do we need to send them off to the audiologist to see if they're losing more of their hearing? Do they need to see the neurologist? Is this something about the location of where the tumor is that it's affecting the hearing, et cetera, et cetera. So again, woo, it just is blowing up the E&M medical decision making. So the focus ended up being, when we're educating our providers, was on adding specificity to their diagnoses, right? And the quality of care as well as medical necessity. So it's not a matter of, okay, this is what's wrong with the patient and this is what I did to fix it. No, we got to expand all of that. In other words, did I have to contact the neurologist for the patient? Did I have to set up the MRI? And that's another thing. Medical decision making. Some insurances are going to say, well, when you do things like that, you got to have an X-ray, then you have to have a CT, and then you have to have an MRI. No, we're past that. We're straight to an MRI because we have a brain tumor. We're not. There's nothing going to show up on an X-ray for this particular patient. And so they have to let the payer know that, why are we jumping to an MRI? Well, because the patient has a brain tumor. We're not going to see anything here on an X-ray. So therefore, medical necessity supports that quality or amount of care that's being given, right? And again, we do have to kind of change the mindset of our provider to let them know what the payer expects. And this is very painful for them in most incidences, because especially when they first come out of med school and stuff, they're all hot and ready to start curing, and saving the world. That's what they went into medicine for. And yet we come in and say, oh, by the way, you're required to document da 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 da, or we can't get you paid. It's like, what? I didn't know that. And so again, we have to work together as a team. And one of the best things that a provider can do is having quality CDI person in their office, as well as a facility is having a CDI person in their office to be able to translate all that information for them. So part of this CDI initiative that went into effect was to help build that structure and make the EHRs compliant and help with templates for document improvement. But of course, you're always going to have pitfalls when you're dealing with an EHR. And sometimes the provider is right on board, right? And honestly, think about this too. Think about the process that you go into to become a doctor. So you go your 4 years of undergraduate school, and then you get into med school, and then you may you do an internship, and then you may decide to specialize in something. And so this whole time you're being exposed to EHRs that you're learning from your med school, which is pretty narrow focused, right? Because their focus is not how to put things into computer. It's making sure you document the disease process. And then you get out there into the world and you're doing an internship, and you're exposed to whatever system, whatever EHR that group is using, okay? So if you are in, let's see, I know about WashU because we lived in St. Louis, and where my husband was getting his education was right next to WashU. They have a fabulous med school. Or MU was also one that I was exposed to. But the EHR that the interns that were at the university in St. Louis and the university in Columbia and everything, those two hospitals use two different EHRs. So whichever one they were trained on, that's the one that they know inside and out, most likely, right? Now, they go and they specialize and they go out to California and they specialize. That's the EHR. Now they've been exposed to two EHRs. Now they set up their own practice. And let's say they want to go back to their hometown. They have to pick out an EHR. And this salesman comes in and convinces them to use this EHR. So now they've been exposed to two, but the learning curve is again, and that's not what they got into medicine to do, to learn how to use an EHR. But that's part of the aspect that they have to be exposed to. So they hire a CDI person to help them make those decisions. So the pitfalls that they fall into is making sure that all of the information for that patient's care is in that EHR. You know, and so they look at it from a medical standpoint, and then your CDI person comes in and looks at it from all the other standpoints that in the office that's going to be pertinent moving forward. They want to make sure that you're not dealing with outdated information and that there's no misinformation put in the record. When you anytime that a provider can use something to save them time, they're going to do it. Because how many patients is that provider going to see in a day, right? You know, they want to see the maximum amount that they can in a day. Why? Well, because they want to help people. And secondly, because it's investment in time. You know, the more people that they can see in a day is going to mean more money in their pocket, and they have a major student loan to pay back. And even if they've been in practice for a long time, maybe they're wanting to bring in another specialist. So the practice has to be profitable, or they can't pay the CDI. They can't pay their compliance person. They can't pay the nurses. They can't pay the front desk staff. They can't pay the light bill, right? And the advertising for their practice. So all of this weighs on them, right? And they got in the business to cure and, you know, make people better. So whenever a practitioner can save time, they're going to. That's their thought process. So if they get to pick from a list, that saves them time. Now, in the past, when we didn't have an EHR, they would just write down, okay, hypertension. They would write down diabetes. They might not even think to say that it's type 1 or type 2. They're just going to put DM down. And then if that patient has an ulcer, you know, they're just going to write the ulcer. But we had to know in the past, was that ulcer related to the diabetes or not, right? Now they don't have to think about that. It's all has a causal relationship, but they had to be trained in the past to say, hey, you've got to link these for me. You got to say due to or not, or I can't pull it together. You know, I need to know specifically, is this has a relationship with this diagnosis, or are they separate? And to let me know that, you'll document, with or that it's together. Now, if they can pull from a list, they're going to pull from a list. But what has to be in the list? Who determines what's in the list? Well, if you're picking from a diagnosis of everything that's related to diabetes, right, the EHR is going to just grab everything with diabetes and put in that list, and they have to scroll, and so there's an ability to fine tune your EHR with flag words and sometimes to make it easier for your provider. Now, if you have an endocrinologist, now they're going to have a massive list, but if you have a PCP, their list isn't going to be as big. We need to know first, what type of diabetes do they have? Type 1, type 2, or is it something else? And it's probably going to be type 1 or type 2. Then after that, it's going to give them a choice. Is there any other, it's not going to be always just diabetes by itself. There could be some other causal relationship in there. And we know now that the coding differentiates that, and we have guidelines for that. But the provider doesn't care about the guidelines that we have for our coding. So if they can do a list, they will. But built into the list is non-specified. So if they don't want to have to think about it, then, and I'm not saying this is a bad thing, I'm just saying that if they're not educated in what all this other stuff means for us, they're just going to put unspecified, unspecified, unspecified. But then we read the documentation and realize, oh, wait a minute, no, it's not unspecified. We've got specificity here, right? So we work as auditors as well as CDIs. So, you know, ultimately, without a higher specificity of a type of CHF, it may not constitute the medical decision making to get to a higher level, right? Because it's just CHF unspecified. But is it CHF with systolic and dystolic? You know, things like that. Why are you doing these other tests and stuff? So again, we need to help educate our provider in those nuances. A lot of times our providers are just under the assumption that it doesn't matter. You know, he paid or she paid you to get to the highest specificity with the codes, and they don't realize maybe that there is a difference in the specificity, and we're dealing with not just the CPT codes or the HCPCS codes for Medicare and everything, but these codes have an RVU associated to them. Now, we are not in the business to pick codes that give higher reimbursement. That's not what we're doing. And that has to be a blatant thing that's taught across the board. However, the provider still needs to be aware of this, because then it makes sense to them why we need the higher specificity, because there's RVUs associated to this. That is, you know, we want the provider to be reimbursed for the work that they're doing. And so we need to like pull out of their brains this higher specificity if that's what's there. Otherwise, they're thinking, just grab the code, you know. So again, it's not about the money, although you know that you're going to have a provider say, well, which one pays out more? Tell me what I need to document so that I can, you know, they're frustrated. Just tell me what do I need to document to get, you know, this one versus this one. You know, what do I do? So again, rein it in. It's not about the money. It's about the highest specificity we can get. And when they get to that point where they're saying that, then there's a break in that liaison relationship, right? You're there to take that burden off of them as the CDI, to give them the education that they need, and so that you're both speaking the same language. All claims are going to have those CPT and HCPCS codes, but they have to have the documentation to back them up. We have to show medical necessity. We have to also show that the diagnosis is backing up the CPT or the HCPCS. Whenever we talk about medical necessity, there is, again, the code set, the ICD-10, that gives us the medical necessity, and ICD-10 is fabulous. It is a much more specific code set that we had than ICD-9, and it's expandable. So everybody, when it first came out, they were talking about how it, you know, more than doubled in size of the code set, you know, and the codes that we got to choose from. But it wasn't a big deal to people that were coders, because it gave us higher specificity, and there was no guesswork. It's not, you know, it's more black and white now. There's less gray in there. We don't have to use unspecified codes as much as we used to, because we can define with the code set with ICD. And honestly, I see eventually, not just talking about ICD, but ICD PCS is a much better code set than CPT, a whole lot less gray in it. And I can see it moving over and taking over CPT eventually, because again, I like to say it's What is ICD-10? It's ICD-9 on steroids. You know, it's woo, bigger and better. In with PCS, I see it being more, it's not, I don't think of it on steroids. I think of it more as a lean, mean fighting machine. You get straight to the point very quickly. You know, it's a really fine-tuned, exact code set. A lot less guesswork there. And so I appreciate PCS. But again, we have less unspecified reasons to use unspecified with ICD-10. Documentation, though, that's the key. That is how we get to the highest specificity. And again, there you go. That's that liaison work I keep mentioning. So what are these carriers? What do they want to see when we need to have the basic CDI? Now, CDI does not follow just diagnoses and the procedures that are done with the patient. It also involves all of these demographics about a patient. That's part of CDI. So let's change from what's wrong with the patient and what we're going to do to the patient to the information that we need for the overall care of the patient. And that falls under things like date of birth, current address. Now, this is where that front desk person is the backbone of everything else that's going to happen to the patient. They're usually the first contact. They're probably the ones that picked up the phone and made the appointment for the patient. They're the ones that the first person that the patient sees when they come in through the door, and are making sure that all of the information and the documentation that patient's filling out is accurate. So date of birth, current address, work phone numbers, home phone numbers. If that nurse needs to call and follow up on that patient, we need a phone number. We need to make sure it's a valid phone number. Is the person married or not? You think, well, why is that really important? Well, first of all, it matters if the patient is married and uses their spouse's insurance, or is it their own insurance? But it also constitutes the care of the patient. If this patient is starting to go through dementia, are they married? Do they have someone at the home, the caregiver, to take care of them or not? You know, so the providers looking at that to see when, you know, are we going to need to start thinking about talking to, or am I going to be talking to a spouse, or am I going to be talking to a sibling, or am I going to be talking to a child of this patient to talk about the care, the ongoing care for that patient? Who's the employer? Insurance information, right? That's where the employer comes in. The employer also is relevant to the patient's care, because what if they got injured at work? But let's say that it's not that they got injured at work, but that they are in a job that is physically strenuous. And what if the patient's diabetic and is having problems with their feet, but their job requires them to be on their feet all day, right? That's part of the patient care. That's part of what the provider's looking at and saying, you know, we got to have a serious conversation about your career path, because at the rate you're going, you can't be on your feet all day long anymore. Your diabetes has gone to the point where we need to consider something that's less strenuous on your body. You know, so employer is important. Insurance coverage. Why is that important to the provider as well? Does the patient have the ability to pay for services? So let's say the provider says, you know, I want to put you on this medication, but I happen to know Medicare will not pay for this medication. Do you have the ability to pay for this medication? If not, then I need to go back and look at it again and come up with another medication that is going to benefit you. Or I need to do a little research, because this is the medication I want, but I completely understand, you know, out of pocket, this is going to cost you a lot of money. So if we're not going to go down that path, let's come up with another choice. Unfortunately, that's, you know, just the way it is. Advanced directives. What's the patient's plan for the future? You know, if a patient has gotten to the point where their dementia is at a stage where they are not going to be able to, before long, they're not going to be able to make decisions for themselves. So do they have an advance directive in place? Do they have somebody that's going to be the person that's in charge of their care? You know, maybe it's the provider that brings that subject up with the spouse or the children of this particular patient. Especially when we have chronic conditions or conditions that are terminal. Complete and current problem list. This is something that also can be a bane of our society when, as coders, when we look at problem lists, as the pendulum swings back and now the diagnosis carries more weight than it ever did before, right? Now we need to know that problem list is accurate and that all chronic conditions are being captured. Even if the patient's just coming in to have cerumen cleaned out of their ears, they need to have a problem list that says, these are the current chronic conditions that my patient has that, you know, I'm not treating those today, but I'm aware that the patient has COPD and the patient is a diabetic and then the patient has, you know, whatever. These are chronic conditions that I attest to the patient having. That is something that's going to have to be done on EHRs as we get into risk adjustment and that aspect of it, and as the pendulum swings to reimbursement being based on the diagnoses. Complete and current med list and chronic medication documentation. So again, if I am going to put the patient, I'm just cleaning their ears today, but I have a patient that's a COPDer and I'm not addressing that, but if they're on they're a COPD patient, I want to make sure that I have all of their inhalers listed on their med list, right? And that it's up to date, you know. And then list for allergies and adverse reactions, as well as your PFSH, you know, what's your past medical, family, and social histories, all needs to be documented and current every time. So every time that patient comes in, whether it's just to have their ears cleaned out, or is it because they broke their finger, or, you know, whatever, all of that stuff needs to be attested to. Now, is it going to change the E&M code? No, they're just attesting that, yeah, I verified, yep. I'm just making aware that all of that is current on the documentation. Most of the time, the carriers are going to want you to have, or you need to have, the patient's demographic and biographic data. If there's any preventative screenings and services when appropriate, why is that being done? You know, why and you probably have already noticed this as you're looking at documentation, that have you noticed that shift that now there's a list of, did the patient get a colonoscopy? Did the patient get their prostate checked? Did the patient have a mammogram? You know, all of this stuff is, you know, education given on all of this, you know, is preloaded in the EHRs. And that's because the insurance companies are wanting, and they pay the provider, they'll say, you know, if you can get a percentage of, for every patient that you have that's 50 and above that gets a colonoscopy, we're going to give you $50, because we want to induce you and our patient to have these preventative screenings. It saves us money in the long run, right? So how it works is they induce you, you know, give you incentives to do this. So you build that into your EHR so that after a while that they see that, hey, this is working, then they're going to start penalizing you if you don't, right? That's the way this stuff works. So preventative screenings and stuff are built into the EHR. Pertinent subjective and objective information, that's kind of, you know, common. We know that. The diagnosis and impression, labs and everything, all of this other stuff is commonly built into these EHRs. But part of the CDI has to come in, and we're usually, when we think of this, we're saying, okay, does the plan, is it consistent with the diagnosis? Right? So the plan and care. The patient came in to have cerumen cleaned out of their ears. Why are you ordering an MRI? Why? Oh, because the patient has a brain tumor. Oh, okay. Yeah. Okay. That's consistent, but we need to clarify that in the documentation. There's a disconnect there. Missed appointments, no-shows, all of that needs to be built in and shown. Evidence of inpatient or emergency visits. Why? Well, if the patient has a brain tumor and they went to the ER twice last month and you're the PCP, you need to know that. That's going to change their plan of care and the medical necessity for things that you're having done with that patient. Consultation summaries and stuff, medical necessary documentation, and making sure that everything is legible and signed. I don't know how if you guys have had training in risk adjustment, but because of my time in risk adjustment, the first thing I look at, because it's kind of drilled into your head, is I go to the bottom of the document and I make sure it's a valid e-signature before I look at anything else. Okay, I look at the patient's name and yep, that's the patient that I'm supposed to be working on. And maybe if this is the date that I'm supposed to be looking at, and then I immediately scroll to the bottom of the page and I say, do I have a valid e-signature? Because in risk adjustment, if you don't have a valid e-signature, you're not capturing anything anyway, right? So, work smarter, not harder. I was just looking here real quick because Skylar, who is one of our SMEs and stuff, he makes a good point that I want to bring up. Is depending on your level of access in the EHR, one can see which part of the notes are copied and where from. That's right. Okay, so if you're a CDI, if you're a compliance officer or CDI, you're going to have access to that component, and you're going to be able to tell if you have a provider that's got a trend of copy and paste. Now, again, there's nothing wrong with copy and paste if it's verified and validated by the provider, right? But when you see that you've got a person that they're copy and paste, and that patient's been on a antibiotic for 6 months, that should be a red flag. That means they're copy and pasting, which is okay, but they're not validating this information is accurate. And really, all of the stuff that we're talking about on this slide right here, who's ultimately responsible for that? The provider is. The provider is responsible for making sure that the patient's date of birth is correct on the documentation. That's why they hire the CDI to make sure everything is in place, right? They hire the front desk to make sure that, hey, you're getting the employer information, or that they're the RN specialists that they've got following up with that patient's care and making sure that we have all the documentation we need from the ER visits, from those 2 ER visits last month that my patient had. And I'm saying, let's say you're the PCP from their standpoint, right? They're responsible for all of this. Their head rolls if there's a problem, okay? But they can't do it all because they got into the business of practicing medicine to make people better. So they hire a CDI, a compliance officer, a front desk, a really savvy clinician, to do all of this. And so it's your job to work with that provider to make sure all of this is compliant. And like Skylar had mentioned, your level as a CDI, you're going to be able to have a higher level of access to patient content versus the person at the front desk. Good stuff. Most of the time, when we do a documentation review as a CDI, we're going to be doing audits. And remember, you embrace audits. You want to do internal audits all the time. You need to have a standard and a protocol of how many times we're doing audits. Now, if you're working for a general practitioner, let's say you're in family medicine, you may not be doing as many internal audits as if you're working with a physician group that has 100 providers and they're all specialists, right? They're going to do a lot more audits than one GP that works by themselves in especially in a small town. Now, I'm not saying you don't do internal audits. You do them, but you just probably aren't going to be doing them as often as you would be if you're a facility or a large physician group. But you embrace those audits regardless. And if you don't do these audits, then honestly, as a CDI, you're not doing your job because you were hired to help that provider, just like I said previously, right? They can't do it all, but they're responsible. It's their name on the dotted line. So you're the specialist, and that's why you're the liaison and both educating each other. So CDI is probably, you could be a CDI and a compliance specialist at the same time. They kind of work hand in hand, but it's kind of like coders and billers. They still have two different roles, but someone can carry all those hats. But as the CDI, as the auditor, internal CDI person, you don't want your practitioner to be vulnerable. And so you're the one that's going to be in charge of these audits, most likely. With CDI work, your role is to ultimately avoid those inaccurate claim submissions. Okay, so documentation, but why are you doing all this and making sure everything's copacetic and stuff? So that we aren't billing inaccurately. So the process to help ensure that this isn't going to happen is multi-dimensional, several fold. One of the ways, again, is that you're going to be that liaison. You're going to be right there talking with that provider. You're going to have a good relationship with the provider. If you don't have a good relationship with the provider, then you're not going to be an effective CDI. It's as simple as that. I always suggest bribing with chocolate, but maybe your provider doesn't like chocolate. But again, that's where, as the auditor and the CDI specialist, you have to have good communication skills, right? You have to be able to bend. You have to be able to take criticism, and you have to be able to communicate as well and give criticism, constructive criticism, and you may have the best provider in the world with a great personality. But you could also be working with a provider that is a type A personality that doesn't have a lot of time to focus on these nuances, right? That's why they hired you. They'll tell you, that's why I hired you. You fix it. Okay, I can fix it. However, this is the information I need to be able to fix that. So how are you going to communicate that? You're going to do queries. And there is a standard for queries. You as a CDI and an auditor are not a lot of times you're not a clinician and you are not a provider. So you cannot lead that provider. You can't first tell them what pays out more, right? That's kind of a no-brainer. We know we're not going to do that. But you also can't practice medicine. So when you ask that provider that, when you did this procedure, did you do XYZ or did you do, ABC? Now, you can ask in a like multi-choice way, but you can't go up and say to the provider that, hey, I was reading your documentation and I'm thinking you did XYZ. Is that true? Or it looks to me like you also did ABC as well. Can I code that? Did you do that? You can't do that, because then that ends up being like you leading the provider, and you can't step in that realm of practicing medicine. Or I just happen to know that if you do XYZ, that ABC is also done. I want to code for that. Can I code for ABC? Did you do that? So let's talk about queries and the proper query. And let me tell you, this is something that's cracked down very heavily for documentation, because again, it's you can fall into that trap without meaning to, in leading that provider as well for reimbursement purposes, and everybody can get in trouble for that. So the query is actually ultimately, a query just means you're asking. You need clarification. So that's the layman's terms of what a query is. So when we do improving of the documentation, one of the things that we're going to do is be querying a lot. You have to have a good relationship and communication with your provider, so that you can say, when you query them, that if you do XYZ procedure, I need clarification from now on. Is there an A component, B component, or C component? Because that's going to change the way that that we code this. We need to know, is it an open procedure? Is it a subcutaneous procedure? Or is it an did we do a laparoscopic that turned into an open? Now this is all kind of no-brainers. They're going to document that stuff. But as an example, these are the things that I need to see in the documentation, so I can make sure that we're coding to the highest specificity. There's different codes for that. And so you're informing that provider. And then in turn, you'd be, and again, this is extreme examples, but when you see that your provider is not documenting whether it's an open or closed procedure, which heaven forbid they did that, right? But you're seeing that, you need to be able to go in and tell that provider, I need to see this in the documentation, because this is basic for us to be able to get the right code. And so as your CDI, this is what I need to see. How will you be documenting this in the future, so that I can educate the rest of the staff to be able to abstract that appropriately? And then they come in and say, okay, whenever I do an open procedure, this is what I'm going to say. When I do a laparoscopic procedure, this is what I'm going to say. When I do a laparoscopic procedure and it converts to an open procedure, this is the documentation that I'm going to be using. Very good. Thank you very much. And now everybody gets educated. It puts in your compliance notebook, blah, 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 et cetera, right? So ultimately, why are we doing that? Because we have to justify medical necessity. We have to be able to get to the highest M codes with medical necessity showing that, and we want to help get reimbursed, for that. So again, why you're telling that provider, why he says, well, why do you need to know how I opened up the patient? Okay, then you're going to say, well, because reimbursement is different on that. Now, you don't have to tell them what the reimbursement is and if it's higher or lower. Of course, they're going to want to know. But what you're saying is, if you do something laparoscopically and then you have to open up the patient, that's a different reimbursement level. And I want to make sure that you're being reimbursed for the work that you're providing. And without that documentation, I can't give you that. And it's like, oh, okay, makes sense. Okay, well, I'm going to make sure that I document that going forward then. Let's talk about this Social Security Act section from 1862. It states, no Medicare payment shall be made of items or services that are not reasonable and necessary for the diagnosis or treatment of an illness or injury, or to improve the functioning of a malformed body member. So what does that mean? We will have clinical documentation based versus diagnosis. So we need clinical documentation that the patient has a BKA. We can't just say that the patient has a BKA, right? We need clinical documentation stating that the patient has a BKA. Thus, you are going to have a red flag if you see in the exam of the extremities, you have good bilateral pedal pulses on a BKA patient, right? Clinical documentation did not validate that BKA. There's a red flag there. And the reason I say that is I've seen that more than once. When you've been doing this for a while, you get to see some really unique stuff, especially when you've been in risk adjustment, because you get to see documentation for multiple EMRs all across the United States. And so that's one of the reasons I love risk adjustment. Then we have to show medical necessity. Thus, for the diagnosis and the clinical documentation, how do we determine that? Because of the symptoms, the signs and symptoms, right? When you are a CDI, that is, to me, no particular entity that works in this team is above one or the other, okay? So again, that person at the front desk is just as important as the RN that follows up with that patient after they've started a new medication and gives them a phone call at home. It's just as important as the provider that makes the medical decision making, just as important as the person that's assigning the codes, right? They are all in a team. And if you have that mindset in the office, then you're going to have a really, humming office. It's going to be fine-tuned. But what you need to know about the importance of the CDI is, and I think the compliance person is also a really big part of this. And often your CDI is your compliance person and your auditor, right? That's why we spend so much time in this auditing course talking about these aspects. But the CDI is the one that makes sure that the documentation is all smooth so that everybody else can do their job to the best capacity. So you will hear this typically: we got paid, so the coding and documentation must be correct. No, a CDI knows that that is not correct. When you hear that statement in an office, then you know that there's a disconnect somewhere in that team, and someone is not knowledgeable. And it could be the practitioner, it could be the coder, it could be the person who's sending the bills. A CDI and that auditor is going to see a red flag if they see every single time an E&M goes out, it's a 99213 or a 99214. And a lot of times they're 99214 straight down the board. Well, I gave a prescription. It's a 99214. I don't care that the person is recovering from a heart transplant. He's a 99214 because I don't want to get audited. Yeah, this person just had cerumen cleaned down to their ears, but I gave them a prescription for Debrox, so it's a 99214, and we just keep getting paid, so it's got to be the right code to use for E&M. No, and I know you guys have heard that before. It's like, no, we just always use this one midline code because that way we know we won't get in trouble, right? It's because if there's overpayment, it's going to outweigh the underpayments. No, that's not the way that it works. That should make a CDI break out in hives or sweat or something. So you can't assume that everything's going fine because we're getting paid. No, that means you're racking up red flags, and they're going to swoop in eventually and get you. And it doesn't matter if you're a GP sole provider in a practice, or you're a multi-specialty entity or a facility. The insurance, the payers' systems, they look for red flags, and they may be just building their case. They're just waiting. You're in a line to be audited and monitored, and especially if you are dealing with government entities as being your payer. So I'm talking about Medicare, Medicaid. And when they come in and they hire people that get paid to find mistakes. So they're going to tear everything apart until they find the mistakes. And underpayment is just as bad as overpayment. So again, you can't use that as a, and you hear this a lot, like, we're getting paid. So they will potentially drop you as one of their providers if you're constantly doing underpayments, just as well as if you're doing overpayments, because they show that you're not being compliant. Obviously someone doesn't know what they're doing, and you're a risk to them, and so they'll just boot you out. They won't renew your contract. But government payers are absolutely the ones that are going to come in, and when they find problems, there's penalties, and ultimately, if they can show that it's fraud and abuse, you go to jail. So again, who's on the dotted line? That provider. But now the coders also, you're the one that was hired to be the specialist. If you knew that you were doing something wrong, then your head can roll too. The medical record, number one, has to be complete and legible. Legible is a big thing because in the past, everything was written by hand. And if you, I remember this one provider that had the most beautiful penmanship. It was very straight up and down, everything. There was no loops in it. It was very straight up and down. And when he printed, everything just almost looked like it could be a font, but it was very narrow and like this. And so you thought, wow, that's beautiful penmanship. I'm not going to have any trouble reading that. Oh yeah, it was difficult to read because sometimes you couldn't tell an F from an L or a T because everything was like this, but you got to where you knew what they were saying. Still, whoo, beautiful penmanship doesn't mean that it's legible. And when we talk about legible with EMRs, EHRs, and stuff like that, you can still have problems with it being legible because when things are scanned in, especially scanned in from hard copy, if we maybe pages get flipped upside down, pages get folded, and so on and so forth. So again, it has to be legible. Copies of copies of copies end up being faded, or they have a dark border on something in the font. You can't read the font with the dark border because they've got this dark blue border in their information. Again, that things like that are you have to think about that. And who is in charge of that? Your CDI, right? It also has to be established in the encounter. Why is the patient being seen? What's the chief complaint? And it can't be follow-up. Follow-up for what? Oh, follow-up for medication. No, that is, as an auditor, one of the, a red flag for you is, why is the patient seen today? Follow-up for med refills. No, the patient's being seen because they're diabetic and they need a refill for their prescription. That's why they're being seen. They're not being seen because they need a refill on their medication. They're being seen because they're diabetic and it's time to refill their medication. So there's going to be an evaluation and a management by the provider of if this medication is still working for them, right? And if it is, that's great. So again, don't let your person put in as a chief complaint follow-up and then follow-up for med refill. That's not enough. Physical exam and findings have to be in there. Prior diagnostic tests will all be in there. Assessment and clinical impression and diagnosis. Now, different EMRs are set up with all of this. Like sometimes the assessment and diagnosis and POC will be at the top of an EMR, which I don't like that, but because it's not old school. But again, it could be in different places. Doesn't matter. It just has to all be there. Other things that need to be noted: the plan of care. Everything has to be legible, and the date has to be legible. The date of service. Who's the provider? And not only who's the provider, what's their credentials? Are they an MD or are they a DO? Right? Are they a specialist? That has to be on there. And their name, of course. Now, can they be Dr. John F. Feelgood? Yes. Can it be JF Feelgood? Yes. But it has to be JF Feelgood MD somewhere on the documentation, hopefully on the e-signature. rationale for ordering diagnostic tests. Why are you ordering an MRI on this patient? Because they have a brain tumor. You know, ancillary services and stuff, it all has to be explained. Past and present diagnoses should be assessed. Why? Because if the person is a BKA, you want that on every single document that encounter, that time that person is seen. And it honestly should have, was it a traumatic BKA, or was it due to a diabetic abscess that got out of control and became green, right? Because a person that's a BKA, their plan of care will be different always than a person that's not. First of all, they're going to be more sedentary than a person that has both of their legs. Are they do they have a prosthetic? If they have a prosthetic, they're going to have complications of that prosthetic. I mean, you just don't pop on an artificial leg and everything's honky-dory and you start walking again. No, you trip and fall more often. You're not as steady. Even if you're really good with your prosthetic, you're at risk of tripping and falling. As you get older, that means you could have a Colles fracture. Do you have osteoporosis as well as a prosthetic? Are you wheelchair bound because you have equilibrium issues and you're so you can't balance on a prosthetic? You know, et cetera, et cetera. All of that has to be documented every single time. It's pertinent to the care of the patient, always. Even if they're having cerumen cleaned out of their ears, it's pertinent to the care of that patient. Let's see, treating and consults and stuff all need to be included as well. We need to talk about the patient's progress, responses to changes. Thus, you don't see a patient for follow-up. Follow-up for what? We need to know so that we can see the progress. If it's for medication because they're diabetic, that has to be documented, right? We need to see that in the CC. And because diabetics can go extreme at any time. Even if the person has been a diabetic for a long time, a type 2 diabetic, and they've been a diabetic for 10 years, you never know that one thing can't trip that person up. Maybe they start out with hay fever, it turns into an upper respiratory infection. Next thing you know, you've got a person that's got pneumonia, and their type 2 diabetes that has always been in control is now wonky because the patient has to be put on steroids. Right? You know, so the disease process has to be tracked, and you never know when something's going to be a complication. We have to make sure that the proper code sets are put on in the physician's office, the billing, the 1500 form, and for facility, the UBO form, and that everything is copacetic when we're doing those electronic bills. And the documentation backs it up. The first steps is going to make sure that the documentation meets with those code sets that we're using. And also, if you're not doing an annual audit and maintaining a 95% accuracy with the practitioner, then you've got to start doing more audits. We talk about accuracy in coding, right? For the coder standpoint, you always want to be over a 95%. But we have to also talk about the documentation as well. This whole, everything that we've just talked about has to be hitting the right on target, 95% of the time or more. Because if we're not having that, then we need to have consistent audits, internal audits. And there may be a point where if you're not able to maintain that 95% or better, then you need to have somebody else maybe come in and do an external audit, pay somebody to come in and do some CDI work or a specialty, and says, you know what, we have got a disconnect somewhere, come in and do an audit and let us see if you can identify where it is, and then give us some additional training. Part of your CDI program that needs to be set up for you is, again, that ongoing basis of auditing. And it isn't just about the documentation. We need good claim submission and improvement of our revenue, right? Everybody can improve their revenue. And it's based on coding to the highest specificity due to the documentation. And then also we need to have, when you're starting out with a CDI program, you want to make sure that you have got support from the entire staff, because it is a team that's working together, right? Front desk is just as important. If they're not capturing changes in the insurance card, or that the patient has moved or got a new phone number, they got a new cell phone, went with a new carrier and didn't, and got a new phone number, then, we're not going to be able to contact them, and there's going to be a disconnect. We also want to reinforce that it's important for a part of the compliance for everybody to be working together as a team. What do we do when we build that CDI program? Okay, well, you have the assessment, the implementation, and the maintenance. So we're going to do an audit, see what we need, where there's any disconnect or we need improvement. We're going to implement certain improvements, and then we're going to maintain and make sure that our goal is to be 95% accuracy on everything or better, and then let's get to 98%, Step-by-step approach. What are we going to do first? We're going to conduct a baseline review as the CDI. Then we're going to set some protocols in place to make sure that we can maintain what we've discovered. We're going to develop a query process, in that it's not just you querying the provider, but the provider could be querying you as well. The front desk could be querying the CDI and stuff. So we need to get a process in place where everybody can ask questions in a proper format that meets the guidelines for queries, especially when talking to a provider. We need to educate all of the practitioners, but the additional applicable, the ancillary staff as well, on what is CDI. Get it down to the basics. What is CDI? Why do we do it? The who, what, when, where, and why. Ultimately, that will help build that team atmosphere. Start implementing the CDI program that you set in place. Reevaluate the program on at least an annual basis to make sure that everything's running smoothly, because what works at one point may not work at another point, because something changes. Maybe your provider went out and got specialty training and now is doing some additional services that they didn't do last year. So again, the CDI process has to start all over to make sure that everybody's trained from the front desk to the provider on what needs to be done for that new service that's being provided. Or you add additional staff, or you lose staff, somebody leaves. So ongoing education and training will be standard. Step one. We're going to get that baseline. How do we do that? We're going to get 10 to 20 dates of service per practitioner, right? So if you have one practitioner, then that would be easy. If you have 10 to 20 dates of service, then we're going to audit the medical record for each one of those, and we're going to make sure that we highlight any documentation deficits that we see, any deficiencies. When, I think this is the same. So we got the baseline review, the 10 to 20 dates per provider, and once you audit the medical records, we find the deficiencies, then we're going to make sure that any areas of concern are highlighted. Now, some of these we have talked about in the past, so let's just go through them very quickly. We want to make sure that we aren't overcoding or undercoding the E&M services, right? We want to make sure that diagnoses reported but not managed by the practitioner are noted, right? So if a person has a cardiologist and they go to their PCP, did they have a consult, or did the cardiologist actually take over care for that aspect, for that particular heart condition? So the PCP is not managing that anymore. The cardiologist is managing the heart condition. It's still noted and tracked, and feedback's going back and forth because it's pertinent to care, but who's managing the care? Let's see. We're going to talk about documentation not indicating the status and conditions that are being reported, clone documentation, of course, unbundling, incorrect use or misuse of modifiers. That's a headache sometimes, right? Everybody has to understand the modifiers, and there's always a learning gap on modifiers, it seems like. We're going to look at documentation that make sure it's supporting any procedures that are being done, ancillary services, and then documentation's not signed. That's why you immediately go down and look at that. Make sure everything's got a proper e-signature. Documentation unclear as to who provided the service. Now, this ends up happening in an EHR pretty frequently. Determine the scope of focus. We're going to look at the E&M procedures again and back them up with the diagnoses. We're going to work on recommendations and taking samples of all the practitioners and coming up with like standards for them. The information, make sure that it's available so that to the proper people. So make sure your CDI person has access. Make sure your compliance officer has access to all of the, the compliance officer doesn't need full access like a CDI would, but maybe the compliance officer is the CDI, right? But your auditor has to have full access to be able to look at everything. Not every physician or non-physician practitioner reports the same procedures and services. So do you have a PA in your office? Do you have a nurse practitioner? Then what's the guidelines about what they can and cannot treat? You know, and on top of who has to sign off and how is that done? When you're auditing the individual practitioner, then you have to have a baseline review for each individual practitioner. And we're not talking about just the provider, right? The doctor. Again, do you have a nurse practitioner or PAs in there? Once you get all of this done, then you're going to work on an analysis. And that analysis is going to end up going to the key people in the team for improvement. And we need to make sure that everybody in the team understands what their role is in the analysis and improvement. Not everybody in the office will need the same guidance, and thus not all the practitioners will need the same guidance. But again, we need to make sure that everybody on the team understands what their role is and how they interact with everybody else. So you don't want that front desk person being so intimidated by the provider that they can't query the provider if it's pertinent. Now, are they going to be the contact person for the provider? Probably not, but they need to have enough intuitiveness and willingness to go to their supervisor and say, hey, I'm seeing this mistake. Can you bring it to whoever's attention that needs to be, and then they're caught in on the loop and said, okay, yeah, you identified an error or a problem and we got it to the CDI talked to the provider, and these are the steps, and everybody talks about how they're going to improve that in the team. Before you get your baseline decisions, then you need to keep in mind that what OIG considers acceptable standards is 95% accuracy. So when they come in, they're going to look for 95% accuracy. And that means you need to be shooting for above that. That's why risk adjustment risk adjustment coders are held at a 98% accuracy, 98, 99%. And if you drop below that, then you're audited and additional trainings given to you. Consider reviewing the documentation as well as everything that falls under the scope so that you can maintain that 95% threshold. Also, the practitioner will have, if you have any of your practitioners that are low on compliance scores, they need to be given education and guidance. Again, it may just be that they're new and they don't know. Maybe it's because they, again, like we said before, started out a new treatment. And as the CDI, you need this particular information documented. They were trained on what they need to document for the procedure, but we need this additional documentation so that we can code to the highest specificity and make sure that we're able to code properly based on the documentation, and it supports the documentation. An analysis and report has got to be saved for record keeping. You want to be able to see improvement. So let's say you set up your CDI program, you see that you've got a deficit in your percentage score and you're at 85% on this particular area. Then you need to show improvement. Even if you don't get above 95%, let's say you're staying at 90%, but you were 80%, then when they come in and audit you, they want to see that you're working towards improvement. That's the goal, right? It's like, yeah, we saw an error. This is what we're implementing. We're continuing these audits, and our CDI is working on education for everybody in the team. And we've gone in 1 month from an 80% to an 85, and we see that trend growing each month until we're above a 95%. So that if you're at 85%, not 80, when they come and audit you, they show that you're working towards that. And the compliance department is going to be very involved in that. Step 2, we are going to develop the protocol and continue to manage for the process. Has to be governed by written policies and procedures. So now we've seen the deficit. We've instituted, the CDI has done education and everything. So what policies and procedures are we setting in place to make sure we maintain and keep improving? Well, that's where your compliance officer and your auditor is going to step in and help as a team. Going to be set up to all of the departments as well as the provider, and they're not going to be limited to education, experience, and credentials for hiring a CDI professional, if you need to have one, initial orientation and training, ongoing education and training, again, and compliant query practices and processes for ensuring CDI quality. That's what we're working towards. The CDI may be brought in when when you go in and you do an internal audit and the compliance officer gets involved and says, hey, we are so below average. We're red flagging all over the place. We need to bring in a CDI to come in and help us set this and see how we can do improvement. And then that's the policies that are going to be encompassed. So every program should be tailored for the practice. If you're working for a cardiologist, it's not going to have the same, program in place as a urologist or a GP or a pediatrician or a facility or a multi-specialty group, right? Unlike with hospitals and their CDI, there's no software out there that can really find risk versus having somebody physically come in and do the work, right? So they don't be sold on someone saying, well, our EHR or our EMR has the CDI work all built into it. No, it doesn't. There's no software that can do that. Now, on a hospital level, they can track and statistics and stuff, but for a doctor's office, there's just not that one there. What are we doing? Okay, again, 95% accuracy or better. The ORG standard of compliance is under corporate integrity. And you want to make sure that you rank above 95%, but it may not be every week, but we need to make sure that we're doing this on a monthly basis or a quarterly basis. So examples for developing the protocol, again, what are we focusing on? Our practitioners are 95 to 100% accuracy for 5 records per month before the claim is submitted. Before the claim is submitted. Then your practitioners fall between 84 and 94% accuracy when you review 15 records per month before the claim is submitted. Then for practitioners that fall to 73 to 83% accuracy, then you will review 40 records per month, that's 10 per week, before the claim is submitted. And then practitioners that rate below 72% will be reviewed 100% of the time before it's submitted. That is how you develop a CDI protocol. How do we query the providers? Now, this is really involved in compliance and everything, but every single practice needs to have this understanding. The whole team needs to understand this. When you query, a question is posed to the provider, and you need a little more information to be able to get the proper code. So they can be concurrent, retrospective, or post-bill. It doesn't matter. And the document that is being questioned, you need to look at everything in the documentation, from the progress notes, discharge summary, or a query form that's kept in the permanent record. So if you query a provider regarding an individual document, it's going to be included so that you can show why. Because if an auditor comes in and says, hey, I saw this error, what'd you do about it? Well, I queried the provider. Here's the query. It's a proper query, and this is the information I got back, and this is the steps that we took to improve the documentation, as well as educated everybody on that. You got to have a paper trail on everything. Physician queries have to be clinically based. They have to be fact-driven. They have to be concise and to the point, and they cannot be leading. Right. So that is education that you need to give everybody in the team so they know. Now, your front desk people may not be involved in this, like your clinicians and your coders. However, they need to be aware of it. Okay. So again, you don't need to be telling, it's like, I like to think when your child asks you where babies come from, they just may want to know that, mommies have babies in their abdomen. They don't need to know the whole process, right? Okay, so query. We need to make sure that we query whenever we have conflicting, ambiguous, or incomplete information. And your CDI is going to be able to come in and locate this. It doesn't matter if it's something minute or it's a very huge issue. All the time, whenever you have conflicting, ambiguous, or incomplete information, it needs to be queried on. When not to query, that's just as important, because you don't want to bombard your provider with queries. They get very frustrated, and they're going to tune you out. They're not going to open up your emails. They're going to rush past you in the hall and not make eye contact if they know you're going to bug them constantly over trivial things. So when not to query is to question providers' clinical judgment rather than clarifying documentation. The query process is going to be incorporated in the practitioner's workflow. So if you're using an HER, then this can easily be done. Send queries electronically to your provider, and then you can develop queries if they are sent. Even they can use them text or smartphones, but you got to make sure they're HIPAA compliant and all the information is protected if you're sending your provider a text. But even if you send that provider a text, remember it has to be tracked, right? You may use a secure method to send it related to the patient's data. And if you don't have the technology in your office to do that, then you need to come up with a physical draft letter. Let's see. Other things that you need to be aware of is clinical indicators of a diagnosis, but no documentation of the condition. Query. You can also have situations where you get the diagnosis is billed, but it's not managed under that patient's care. What about evidence of higher degree of specificity? I talked about that several times. Cause and effect relationships. Now we have a little bit more leeway. 2017 with ICD, things changed a little bit, so causal relationships are not as difficult to code. However, we still need to know if there's a causal relationship on a lot of different diagnoses. The treatment is documented without a diagnosis. Again, Why did you do this full exam when the person had cerumen in their ears? Diagnosis is documented in the assessment, but does not meet the documentation guidelines. You cannot document in the diagnosis that the patient is a diabetic with having no indication that you address diabetes in the documentation. That's just a no-go. You can't do that. And level of services not meeting the CPT or CMS requirements, or services reported but not documented, and then lack of detail in documentation. So therefore you would have lack of clarity, maybe with modifier usage, and the documentation is not signed and dated. All of these are going to be reasons to query. The do's and don'ts. Okay, do. What you do need to do is ask the provider for either a procedure or a diagnosis code. You can ask the provider to amend a note or omit information if it's an error. You can ask the provider questions about multi-code code choice format. So in other words, say, I have these 4 codes that are applicable to what you've done, but I'm not sure which one is the highest specificity. Can you help me with that? Use electronic tools so everything can be tracked properly, because we need to put that in the documentation for that patient. And it's really a good idea to have a template, because if you have a template, then you know that you're going to probably more likely query properly. Do not ask leading questions. Don't tell the provider what you need documented to get paid for a service. Now, you can tell the provider what you need documented, okay, to get to that code, because you can show them the code description, right? So you can say, here's the code description for these 3 codes. So therefore, they would know what needs to be documented to be able to get that code. But they don't need to know which code pays out more than the other, right? So that's, don't get that confused. You can say, these are the documentation, this is the documentation I need for this code. This is the documentation I need to be able to use this code and this code, right? You tell me which code meets what you did. And if the documentation is not there, then we need to have, we need to make adjustments and make sure that from this point going forward, we always have this documentation so that I can have clarity. Another time that this happens is at the end of the year when you get new codes in your code set, right? The provider doesn't know about new codes, but you can say, hey, now we've got another code that gives higher specificity. This is the new code. I'm training you on this new code, and this is the documentation that if that we would need to be able to use this new code. But you don't need to let them know that it pays less or more, right? Let's see, send queries on Post-it notes, scrap paper, or handwritten queries. Nope. And challenge the practitioner's clinical judgment. No. And always provide chocolate. In addition, we need to make sure that the query process is assigned to a staff person that is a CDI practitioner to monitor and manage the queries, because you make one query mistake and they can come in and pounce on you, right? And leading is the provider tends to be one of the things that they focus on. So who's going to be in charge, and how are we going to maintain that? How are we going to do it, right? Are we doing it email? Are we going to have a special program put in for that particular practice or practitioner? Now, if you're just a one provider practice, not as difficult as if you're 100 provider specialty practice, or even think about if you're working at a facility. When you determine what you're going to do in the delivery process, then you need to know how long you're going to hold queries and responses. It's suggested that you don't hold them for more than 7 to 10 days because you want the insurance, you want to bill, right? So it's holding up your billing process. Now, I don't mean holding on to the query after it's been answered. No, you want to keep that. I'm saying, how long do you want to wait for clarification? It's really not a good idea to wait more than a week. How do we manage to get the practitioner to respond? Well, first of all, we want to make sure that we know that they understand we're not bugging them, that's not the purpose. We need to find out the personality of the provider so that we can see what works best for them. That should have been all written in the protocol. So what does this provider want? They want all the queries lumped together and they want to address them at the end of every day, or they want them all lumped together and they want to address them all at the beginning of every workday or at the end of the week, whatever. Or they may say, no, I want them, I want you sending them to me individually and I want to address them as soon as I see them. You know, so find out, work out that protocol, and so you can have rationale behind the way you do it. You got to monitor the number and types of queries per month. So if you've got a provider that's getting queried nonstop, well, first of all, they're going to get agitated. And are those queries justified? If they're justified, then some education needs to be done, right, for the provider and everybody as a team. You can have, 3 queries per month. May just need a little guidance. But if you have 60 queries per month, that's a problem. Monitoring the queries, somebody's got to be in charge of that. And everybody on the team needs to be able to understand the process, because that biller is waiting for the coder to get the query answered, right? And so they need to be able to contact the coder and say, hey, did you send the query? Yes, I sent the query. Here's and I'm waiting. And this particular provider likes to look at their queries every day in the morning, first thing, and I happen to know there's 4 queries that they need to look at this time. Or nope, they like to look at theirs on Friday before they leave for the week. So they know they start with a fresh start on Mondays. So this is Wednesday. I'm sure that they'll address it on Friday, right? 4th step, we need to educate everybody. The CDI practitioner is going to educate the clinical staff, the management staff, everybody that's involved. And we've kind of already talked about that. If you are working with a hospital CDI, then that's going to be a different process than working with a doctor's office, which again, that makes sense. And also, we want to always, as the CDI, make sure that we reinforce that quality is what we're looking for, medical necessity is what we're looking for, so that we can do the correct coding and claims. And it's not all about being a red flag. We just want to be the best that we can be, right? So that if we ever get audited externally, that we're on top of our game, and that we don't want the provider to have to worry about that. We want the provider to be really focused on the practice of medicine. We're there to help them with all this other stuff. The implementation process, we notify everybody the date where the new query letter or the CDI program is going to be implemented. We make sure that all the pertinent people know the policies, the procedures, and protocols. We also have a number of queries built in advance, and meaning we say, okay, if you get more than 6 queries in a week, that's a problem, and that's a red flag. And then we also want to make sure that our providers and staff is trained on the CDI process, so they understand what's coming. And they understand that if they get more queries in a week than what we set as a protocol, then the CDI is going to come in and start asking questions and see what they can do to help the provider or help the staff get trained, so that we're not getting these maybe what the provider sees as unnecessary queries. And if they know that they've got 10 queries waiting in their inbox and in a week, and the standards is nothing above 6, they know in advance, hey, CDI is going to come in and ask questions and want your opinion. So they have to know that they are not being targeted, and that a target date for the implementation and the processes will all be happening. And then we need to make sure that it's the whole reason that we're doing that is for documentation improvement across the board. The 6th thing we need to do is that it might be necessary to reevaluate the program every 30 to 60 days. So we launch January 1st. Everybody's on board. In 30 to 60 days, we go in and reevaluate and say, hey, you know what? This is not working. I can't do the queries coming in on an individual basis. I'm just too busy. It's bothering me. I want to pick one date every week to address all queries that come in. Okay. Now Dr. Jones is going to do it this way, whereas they initially. So everybody down the line understands that this is changing. Or we see an issue in this problem, so we're going to have a meeting. We decided that now for the next 3 months, every Wednesday, we're going to do a CDI meeting 15 minutes before we start in the morning, every morning, regardless. Okay. Reevaluate the efforts of CDI to make sure there's no, nuances that need to be changed. And we need to see if maybe we can drop the number of audits that have to be done as people are improving and the CDI program is being more effective. Then we need to maintain. Everything, we've been doing this for 6 months. It's going great. We need to maintain. So we're going to set our regular monitoring in process. We're going to have continuing education, and we'll do it once a month instead of every week. We'll do some additional audits coming in, and we'll focus those audits on something that we saw that was kind of a red flag and everything. So we're not doing a broad audit. We're fine-tuning those audits, and we're adjusting the program as we go. 7, we're going to do, of course, ongoing training. We're going to find out if there's every quarter, we're going to train the practitioners and the staff. Again, as this is ongoing training, it doesn't have to be done as often as it was being done in the past, but we have to remember that how we train one practitioner may be different than another practitioner, because as the CDI, you're going to understand their personalities. Is this a laid back, easygoing, doesn't mind change practitioner? Or is this a type A, rigid, almost, autistic in their personality, where everything has to be focused and everything has to be done in a certain way and doesn't like change, or it messes up the rest of their week? Right? They're easily agitated, when they do things. And again, you could have nuances and differences. Also, another thing you have to realize is you have to know your practitioners, because it isn't all about what's happening in the office. What's happening in their life. Is this practitioner going through a divorce? You know what? Little things are going to agitate them. Is this practitioner getting ready to get married? Right? Is this practitioner getting ready to have their first child? Right? Does this practitioner have 5 kids, and in the summer they have a lot more trouble focusing on things than they do when the children are all in school? Right? So again, this is maybe this practitioner just lost a family member, and that's encompassing, they're going through the grief process or something like that. So again, you have to know the CDI has to be in tune with everybody in the office on a personal basis. Quality, this is where we're wrapping up. Why do we do what we do? Why is it important to have a good CDI? Because it's going to make sure that anything that the provider needs to be aware of is addressed, because they're busy. This isn't what they're focusing on, right? They want to practice medicine. Also, they're expecting you as their CDI to take that burden off of them. And they want to trust you to only help them, and give them the information on where it's necessary. They don't need to know everything that's going on in the office. That is not what they want to focus on. Now, you may have some providers that are really hands-on on everything, but for the most part, that's why they've hired an auditor and a CDI. They want to make sure you are the one that's handling everything for them, and then make sure they're being compliant. Make sure that if, also the CDI that is hired for the office, if you're an auditor that's going to go in and help them get a CDI, that person's certified in that, and they have the background for your specialty, especially. So if you got a GP person that has all this experience in as a GP CDI, but they're being hired for a facility or a multi-specialty group, and they worked for one, well, is that maybe the best fit? Well, maybe it is. Maybe they're ready for that. But a person that has always been a CDI for a facility is maybe not the best fit for a CDI for a one provider GP, right? So again, make sure they're a good fit. You can make sure that they can provide the accuracy that they need, that they can help you get accurate reimbursement, that reduction in non-compliance risk is a goal of yours. Physician education, they got to be able to do that in a way that doesn't agitate the provider. Motivation, their personality also is going to play a huge part. And that they are on board with the team. The team effort, I think, is very important. So that's going to wrap us up. You know where to ask questions, but let me just now go and address any questions that I see on here. I'm enjoying this webinar. Thank you. I'm glad that you are. Skylar addressed things. Building a relationship, Skylar is saying, is so critical, and not just with the provider, but with the whole staff, because you have to have that team mentality, you know, loyalty and really wanting to be on board. You don't want that Debbie Downer in there anywhere in any aspect of the office to bring everybody down. Sherry says, teaching the practice physicians to know what they need to know as coders. You know what? I have known a lot of providers that became coders just so they could communicate better for their coders. You know, they didn't do it for, well, they did it for themselves, but they didn't need that education. They didn't need to get certified. Maybe they just took the training, but they knew how important it was for their reimbursement and that liaison relationship to work, that they became coders. And that's the providers you want to work with, right? Can we take verbal diagnoses from the doctor? If so, does he need to add it to the record? Yeah, it has to be added to the record, because you have to have, everything has to be documented. If it's not written down, it's not done. So no, you can't take just a verbal diagnosis without it having documented somewhere. If an MD states I'm not sure what that was, social and family history as noted on nurse documentation, is this sufficient? Yeah, if he refers back to that and validates it, then it's okay. But he has to document that he approved it, that the nurse took that, it'll say CPC-I or C nurse's note, and then he's signing off on it or she's signing off on it. So yeah, you can. But you cannot just take, the only thing that you can use that a clinician documents for coding is a BMI with the diagnosis of obesity and stages of ulcers. You can do those. I think there's something else. I can't remember what it was. Okay. I think that's it. Yep, we will be getting a CDI. We're working on that. We're working on the curriculum right now. Okay. All right. So that's it. Thank you guys for joining us. No, it's a lot of information, woo, but this is good stuff. And this is going to be pertinent and helpful. This auditing course is going to be helpful for you. Whether you get the auditing credential or not, it makes you a better team member all around, doesn't it? Okay, that's it. Bye, guys. See you next time.